Good afternoon, everyone. Thank you for joining us today. This series was made possible in part through the generosity of Amgen, and we thank them for their support. My name is Mike Spigler, and I am the Vice President of Patient Services and Kidney Disease Education here at the American Kidney Fund. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we are glad that you've joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits, and you will not receive a certificate upon completion. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Susan Wong. Susan is a nephrologist at the VA Puget Sound Healthcare System in Seattle and an acting instructor in the Division of Nephrology at the University of Washington. She received her undergraduate degree from Brown University, her medical degree from the University of Pittsburgh, and her nephrology training, master's degree in epidemiology, and graduate certificates in palliative medicine and clinical ethics from the University of Washington. She is a former recipient of the American Kidney Fund's Clinical Scientist and Nephrology Fellowship and is currently supported by a grant from the National Institutes of Health. Dr. Wong conducts research on treatment practices and end-of-life care for patients with kidney disease. Her work describes the patient, provider, and system-level factors that shape these treatment practices and their downstream clinical outcomes. She hopes that her research can help to inform shared decision-making between patients, families, and providers for treatments that best reflect patients' values, goals, and preferences in healthcare. Thank you, Dr. Wong, for joining us. I'll turn it over to you.
All right. Well, thank you so much, Mike, and thank you to the American Kidney Fund for inviting me today to speak with you. I'm really glad to be talking with you today about conservative care for kidney disease. And while I think it's fairly widely acknowledged that not all of our patients will choose to receive dialysis for their end-stage kidney disease, I think there's relatively little information out there about conservative care, and I think that's really unfortunate because it is an important therapeutic option for our patients. And so I hope that with today's talk, I'll be able to provide you with some helpful information about conservative care. I see the slide is already on the next one, and so I wanted to share with you all that this talk was in part inspired by a patient with kidney disease that I interviewed last month. So I split my time between seeing patients and conducting research, and I conduct research, as you heard from Mike, that evaluates the kind and quality of care that patients receive. And part of my research involves conducting one-on-one interviews with patients, an hour and a half long interviews, to understand their experiences with kidney disease and to identify gaps in healthcare that they might face. And so this is an interview, this is a quote from an interview with an 82-year-old man with kidney disease, and he was stage 5, a very advanced kidney disease. And he was telling me about how he was thinking of not doing dialysis, but he wasn't sure how to bring it up with his nephrologist. And this is what he said to me. I can't imagine that dialysis is going to improve anything about the way I live right now. I really don't understand my life between now and when I'm not alive. I suppose I should ask that question, but I haven't. It is almost as if the nephrology clinic visit is not the right setting for those things. It is always one that talks about solving a health problem and getting better and now maintaining a health level and not getting any worse. To ask questions about what happens when it should get worse and what I should be expecting, it seems like it is a different topic that doesn't belong in this discussion, and I don't know where it would belong. And so after hearing his story, it made me realize that I hope that I can use this webinar today to create a safe space to talk about conservative care. So next slide, please. So with today's talk, what I'd like to address are three main areas. Who is it exactly that is receiving conservative care? Why might some patients choose conservative care? And just what exactly is conservative care? So next slide. Next slide, Ashley. Oh, there we go. Thank you. So I did, before I launch into the talk, I did want to make a clarification. I think we tend to talk about the different treatment options for advanced kidney disease as conservative care, dialysis, transplant, as if they are mutually exclusive options. But the truth is that they are not. These are options that are overlapping. And just for example, a patient might begin on dialysis, then transition to getting a kidney transplant, but then the transplant fails, and this person might ultimately decide to transition to conservative care. And so I wanted to just reaffirm that patients can move between these different types of treatment options. For today's talk, however, I'm just going to focus on those who choose conservative care without a plan for dialysis or transplant. So next slide. All right, so who is receiving conservative care? Next slide. Well, from my own research, it's about 1 in 7 patients who reach the very advanced stages of kidney disease, so stage 5 kidney disease, that pursue conservative care. So the next slide, this slide shows, is a figure that shows the different treatment decisions that patients with very advanced kidney disease had made about their kidney disease. The black bars represent patients who ultimately went on to receive dialysis. The gray bars are those who were preparing for dialysis but ultimately died before they faced the decision to start dialysis. And the white bars represents patients in whom there was a decision not to pursue dialysis. And you can see that with advancing age, that white bar gets bigger and bigger. And so the decision to not pursue dialysis becomes more common with older age, such that when you get to the age, above the age of 85, about 45% of those patients choose to not pursue dialysis. The next slide. So not only is conservative care more common among patients who are older, they're also more common among patients who are white and those with other comorbidities, serious comorbidities. I also wanted to mention that conservative care is also less common in this country as compared to other developed countries. So in other countries, for every 1 patient who goes on to receive dialysis, another patient does not. And the next slide shows you a figure of just that. So this is a figure showing treatment rates with dialysis among patients with very advanced stage 5 kidney disease. So the black bar represents patients in the US or in the VA healthcare system where I did this work. The gray bar represents patients in Canada. The white bars represents combined patients in Australia and New Zealand. What you can see is that for younger patients, treatment rates with dialysis are very high, and they're pretty comparable across the 4 countries. But once you get to patients over the age of 75, there's a real divergence in practices, such that when you get to patients over the age of 85, in our country, about 45% of those patients go on to receive dialysis as compared to 5 to 7% in these other countries. And it's not entirely clear why conservative care practices are so different between countries, but I think this information suggests that there might be a cultural component to why patients may or may not choose conservative care. So the next slide. So why might patients opt for conservative care? The next slide. Well, conservative care is an alternative treatment for patients who view dialysis as not something that fits within their life goals. So the next slide. So I think it's important to recognize that when we make decisions in our lives, often these decisions are driven by certain core values and priorities that we hold important to ourselves. My values may be different from your values or the next patient's, and we need to respect our differences. This slide shows the 4 different kind of core values that I commonly hear. This is certainly not complete, but I would say if I had to bin the different goals and values that I hear my patients state, I would say it's commonly in these 4 realms. And these goals often are the major considerations that they're dealing with when they're trying to make decisions about their kidney disease. And these values include values regarding quality of life, or trying to live as well as possible, longevity, or trying to live as long as possible, relationships, or living in a way that upholds their bonds and their roles with the people that they love, and independence, living in such a way that upholds their autonomy. And I want to stress that not one of these priorities takes precedence over the other. There's one value is not wrong or right. We all do what's best for us in our healthcare decisions. So with that, I want to go to the next slide and show you quotes from patients who had opted for conservative care and the reasons why they had made the decision that they did. I think these quotes reflect some of the reasons, but certainly not all of the reasons. And these quotes come from interviews with patients that have since been published in medical journals. And so what you can see here is that some patients might cite letting nature take its course, believing that they had lived a good life, and accepting the inevitability of kidney disease as reasons for why they had opted for conservative care. The next slide, please. Other patients might talk about conservative care as their choice because dialysis would be too burdensome for them. They might believe that the gains with dialysis might not be worth the trade-offs, and that dialysis might be too difficult to cope with, or a fear that they might become dependent on it. So in the next slide. In the past decade, there's also been some very interesting data that has come out of other countries that suggests for certain patients, so seemingly patients over the age of 75 and those with significant other comorbidities, that life expectancy with conservative care might be quite similar to that of patients who go on to receive dialysis. So if you go to the next slide. So this is a table that summarizes some of the studies that have been published so far that have compared life expectancy between patients who received conservative care and those who opted for dialysis. These are patients who are older, over the age of 75, and again with very significant comorbidities. So just to talk you through the table, the first column shows you the author of the study and the year the study was published. The second column is the country in which these studies took place. The third column is the median survival or life expectancy of patients who opted for dialysis. And the last column is the median survival of patients who opted for conservative care. And you can see from the third and the fourth columns that life expectancies are quite similar between patients who went on to opted for dialysis and those who opted for conservative care. I think it's important, though, and I want to say that that these are studies that were conducted in other countries, and what happens in other countries doesn't necessarily mean it applies to patients in our own country. So I think it is important to take this with a grain of salt. But I think this has been very provocative information, and has really led us all to reconsider our beliefs and thoughts about conservative care versus dialysis. So on the next slide. I think it's a common misconception, and maybe it's a misplaced anxiety or fear that if a patient chose conservative care, well, perhaps he or she might suffer symptoms that could otherwise be treated with dialysis. And that misconception, that's really just not true. If you go to the next slide. Next. So this is a table that shows the prevalence or how common different symptoms are among patients who are receiving dialysis versus conservative care, and shows you the severity of each of these symptoms between those who receive dialysis and those who receive conservative care. So the first set of columns on the left show you the proportions, and you can see that the prevalence of these, of these symptoms are quite common and similar between the two groups. Similarly, in terms of severity, so with 0 being not severe at all and 10 being very severe, also the severity level of these symptoms are similar between those who are receiving dialysis versus conservative care. And so what this study suggests is that certainly patients who receive conservative care don't fare worse than patients on dialysis and get similar symptom control as those who are undergoing our best technologies like dialysis. Okay, so next slide. So what is conservative care? The next slide. Well, there's no one set approach to conservative care. You'll find that many nephrologists or kidney doctors practice this in different ways, but I think there are certain core attributes that are universal to all. And these attributes include the availability of conservative care from diagnosis to death, that conservative care strikes this delicate balance between restorative and supportive care. That conservative care is a multidisciplinary approach to care, and that involves people other than just your kidney doctor. And that conservative care really relies on clear communication and anticipatory guidance about expectations and disease course as a way to support patients and family members throughout the course of disease. So the next slide. So just exactly what is the balance between supportive and restorative care? Well, restorative care is a disease-specific approach to care, where the care that is provided is intended to reverse, halt, or minimize the disease process. Supportive care, on the other hand, is a patient-defined approach to care, where care or interventions are intended to reverse, halt, and minimize how disease impacts a patient's life. So next slide. So with a disease-specific approach, you might find that you and your doctor, when you talk about your kidney disease, talk about the kidney disease in the context of physiologic problems related to the kidney disease. So for example, you might talk about the anemia or low red blood cell counts, edema or buildup of fluid in the legs and lungs, acidosis or the buildup of acids in the blood, proteinuria or the development of loss in protein in the urine, or hyperphosphatemia or a buildup of phosphates in the blood. And so how you and your nephrologist might go about treating these different disease processes or reverse or halt these conditions, they would focus on prescribing you iron or EPO or erythropoietin to treat your anemia. They might give you diuretics like furosemide or Lasix to treat that edema. They might give you sodium bicarbonate, also called baking soda, to treat your acidosis. Use medicines like ACE inhibitors, like lisinopril to treat the proteinuria, and use binders like calcium acetate or Foslo, Renagel to help you with the high phosphate levels. Next slide. With supportive or a patient-centered approach to care, there is a philosophical shift in the care. And the first thing you might notice is that you and your nephrologist might prompt you to set the agenda by asking you things like, what concerns you the most? What are your healthcare goals? What's most important to you when facing serious illness? Next slide. And with those questions, in my own experience, what I find is that patients might bring up symptoms that ail them, like fatigue and itching. And for that, then I might talk about how many medications they're on. Perhaps they might be on too many medicines that are interacting with each other or have significant side effects, and talk with them about whether or not they may be comfortable cutting back or stopping some of the medications they're on to help with the fatigue. We might talk about not necessarily adding medications, but trying other alternative therapies or more things like UV light therapies for bad itching, or using emollients, things like that. Some patients, when I ask them what concerns them the most, they might not talk about symptoms at all. They might talk about things like figuring how to stay home for as long as possible, avoiding the hospital. They might want to talk about how to stay connected with loved ones. And when they raise those things, we might talk about things like preparing a living will or an advance directive, recruiting more help at home, or creating legacy. The next slide. With conservative care, it's a multidisciplinary approach to care. There are quite a few members on your healthcare team when you opt for conservative care. I think a lot of these folks you already know, the nephrologists, the nurses, the pharmacists, the dietitians. So I'm not going to spend time talking about these folks. I wanted to focus on four providers in the conservative care pathway who I think are really crucial to your care. So the next slide. So social workers. Now, some of you may have already interacted with a social worker. They are incredibly helpful people to have on your team. And what social workers do is that they help patients and families solve and cope with everyday problems that arise because of illness. They can address emotional problems, financial problems, housing issues, caregiving needs. Many social workers are trained to provide the support directly. A lot of them have counseling skills and counseling background. They also are very good at connecting patients and families with local, state, and federal programs to also build the support for you. And so having somebody like a social worker to help you navigate our very complex healthcare and social system can be incredibly beneficial. The next slide. So chaplains, I'm not sure if many people have interacted with. Chaplains are non-denominational clerics who provide spiritual support to patients and families who face serious illness. And I just wanted to quickly make a distinction between religion and spirituality. Some might say that religion is actually a part of a larger concept of spirituality. But spirituality is a complex and multidimensional part of our human experience. It is the search for meaning, purpose, and truth in life. It is the search for connection with others and the world and inner peace. And it really encompasses our beliefs and values by which we live. I have not ever met a patient who, when facing serious illness, has not thought about the meaning of life. I have some patients who move through this reflective process with great ease. They already have spiritual support from family, friends, maybe a church or a temple. I do have some patients who have a more difficult time dealing with these thoughts and feelings, and that's when I think a chaplain can be really helpful in terms of guiding them through this process. So next slide. Palliative medicine providers are specially trained doctors and nurses who act as consultants to your primary providers. And your primary provider in your kidney disease might be your primary care doctor or your nephrologist. And what they do is they focus on providing relief from symptoms and the stress of serious illness. And they can come in at any point in time during the disease course. They really act as advocates for a supportive care approach. They work both in inpatient and outpatient settings, just like nephrologists. But one thing extra that they do is that they can do and often do home visits, and that can be particularly helpful for patients. The next slide. Hospice. So I think there's also this common misunderstanding that palliative medicine providers are the same thing as hospice. They're not. They often work closely together, but they are different entities. Hospice is actually a set of services that's focused on providing expert care to patients and families near the end of life. Hospice is a Medicare entitlement. That means Medicare pays for it, as does Medicaid and the VA if you're a veteran. And also most private insurances pay for hospice. And hospice services can be provided in patients' homes, or they can be provided in facilities like an adult family home or a nursing home or a long-term care facility. So next slide. So hospice encompasses a range of services. A hospice team is led by a medical doctor. It can be your primary care doctor. It's sometimes a palliative medicine doctor. It's also led by a nurse. They provide medical advice and guidance. They also provide medications that one might need. Hospice also provides 24-hour, 7-day-a-week on-call nursing if patients need extra support at home. They have a team of volunteers and health aides who can provide assistance with personal care needs, light household work, and sometimes companionship. Not all people are comfortable or have experience with being at the bedside during the last moments of life, and so hospice can be there to provide that compassionate support during that time. After someone passes, hospice also provides bereavement counseling. They can provide funeral assistance, and often they have their own team of social workers and pharmacists too to help patients throughout the course of their illness. So next slide. So the path of a patient who might choose conservative care begins very much as anyone else with kidney disease. It begins with routine visits with your kidney doctor, monitoring your kidney function with lab tests, managing the disease with medications. As the disease progresses, you might find your nephrologist recruiting the assistance of other people, pharmacists, dietitians, social workers. They may introduce you to the palliative medicine doctors and to hospice chaplaincy to provide that extra layer of support to you as your disease progresses. And next slide. And I wanted to take just a moment to underscore the benefits of creating these extra layers of support for patients. Everyone describes, I think, the disease trajectory differently. This is how I best kind of describe it and conceptualize it, is that when we're in good health, we seem to have abundant energy to go out there and do things. But when we develop serious illness, we tend to focus our spheres of energy. We focus on caring for our illness, caring for ourselves, caring for our bodies, and our focus and our energy will tend to turn inward. There may be a growing desire to be at home, to rest the body, to rest ourselves. And because of this increasing focus and concentration on the body, on resting, and it being at home, it's really important that healthcare then comes to the patient. It becomes increasingly harder for patients to constantly leave their house to get their care. And that's why I think having people like palliative medicine and hospice who can bring the care to you at home can really be incredibly helpful. So next slide. So as I come to the end of my talk, I hope that this information has been helpful to you, that will help you in facing your kidney disease and the decisions that lie ahead. So next slide. So in conclusion, I hope that I was able to convey to you that conservative care is a reasonable therapeutic alternative to dialysis, that conservative care is best suited for patients when it upholds the values, goals, and preferences of patients, and that conservative care is a patient, and I'd say even family-centered, interdisciplinary approach to care from diagnosis to death. So thank you so much for listening, and I'm happy to take any questions.
Thanks again, Dr. Wong, for joining us and for leading such an excellent webinar. At this time, I do have a few questions that have come in over the course of the webinar. If you have time to answer them, I'll get them right now.
Okay.
First one, as a patient, how would you suggest bringing up this topic with a loved one if this is a direction I'd like to take?
That's interesting. I think one thing that would be helpful is to identify who is it among your family or friends that helps you make medical decisions, that who has been there and who you trust to carry out your decisions, your goals, and your wishes. That person is probably the best person to have that conversation with, or maybe the first person to have that conversation with. And I think what might be helpful is first talking about what their hopes and expectations are with your kidney disease and with the care that they receive, care you're receiving. And you might find that you and your family member are really aligned on what your hopes are. And if they share your hopes and values, and that conservative care seems to best uphold them, then I think that the conversation might naturally flow. I think anytime people talk about serious illness, it's going to be a hard conversation. There is going to be emotions. And I would encourage you, not just patients, not just family members, providers too, is to stay in that moment, stay in those emotions, because they're the things that guide you through it. They're hard, but the answers lie there. I think the next steps on what to do always lie there in those emotions. I hope that helped.
Thank you. Question asked was, how do CKD patients usually die? Is it from cardiac failure if they choose this treatment? Is that usually what ultimately causes them to pass?
Oh, interesting. I think I guess from a big picture epidemiologic standpoint, it's true that cardiovascular disease, heart disease, tends to be the leading cause of death among patients with some kidney disease. When patients choose conservative care for their kidney disease, no, and I guess there's no way to explicitly prove this every time, but most of the time, almost all of the time, it's because of the complications of kidney disease. I don't know if this was talked about in other webinars before, or whether or not you've had this conversation with your patients, with your doctor, is what the natural history of kidney disease is. I don't know if this is the time to talk about it, or if best in the,
feel free to give a little, as best you can, I guess, a little bit of an overview of that. Sure.
Okay. It's kind of similar to what I had said in the earlier slides about this energy. I think one of the striking I think characteristics that I see of the process is that of the energy slowly turning inwards, and patients label this change in energy differently. Some people call it fatigue. Some people call it tired. Some people even say, is it a lack of motivation, a lack of interest? People name it differently, but what I do see is a kind of turning inward of energy. I call it almost a winding down, a dialing down. One might find that they don't eat as much as they as they normally do or used to, that they don't have the same appetite as they used to. There's a growing need to rest the body, wanting to sleep, wanting to rest. Their thoughts, their speech might be slowed. Silence it becomes much more powerful. Just being with another person, even being there silently with them and present with them, becomes increasingly important. I would say those are I think the common things I see. At the last moments, I think, of passing away from kidney failure, often patients are kind of slowly slip into a sleep in a coma, and pass away in that manner. If there are other symptoms that occur, sometimes it's symptoms that you might experience in the late stage of kidney disease, even sometimes on dialysis, things like itchiness, maybe shortness of breath, cramping or pain. What we use is different medicines to treat those symptoms so that people remain as comfortable as possible throughout the course. I hope that helped. Was that helpful? Or, yeah?
I think it was, Susan. Thank you. So we have someone that says, I'm only in stage 2A and have had 2 transplants. I've decided if this one doesn't work out, I may choose conservative care. Do young people ever do this?
So young people do offer conservative care. It's much less common. I personally, I don't know how young you are. Young is such a relative term. I consider 65-year-olds young, so it's hard to know exactly your age. But
29, Susan. 29.
29. 20. So I would say 29 is certainly on the younger side. I have not personally cared for a patient who was 29 who had opted for conservative care, but I think if you're thinking about it, it's something to talk about with your doctor. I think some of the first questions that come to my mind are, what are you hoping to, what are your hopes with conservative care? What are your fears about another transplant or dialysis? What is leading you to choose one pathway or the other? I guess my first would be kind of where I'd like to begin those kinds of discussions with your doctor.
Great. Well, to that point, how do you begin the process of conservative care, and what's the rate of nephrologists using conservative care? So in other words, I guess it's a 2-part question, right? Who should you reach out to first if you're thinking about this on the professional side of things? And just anecdotally or otherwise, what's the rate of nephrologists that are using conservative care?
In terms of who to bring this up with, I think you could bring it up with your primary care doctor. You can bring it up with your nephrologist. I'd say because conservative care is not as common, not all primary care doctors, not all nephrologists have experience with this. And when that happens, that's when I think having a palliative medicine doctor to be a consultant to your primary care doctor and nephrologist can be really helpful. But I think you could bring up this conversation, and actually the nephrologist, primary care doctor, or the palliative medicine doctor can all help begin this conservative care process. When to start conservative care? I have to say it isn't a single time point that this happened. It is an evolving process, and because getting to know a patient and getting to know what's important to them occurs over multiple visits and meetings. It's something that naturally evolves over time with each clinic visit. As I come to learn what's important to them, as I come to learn, do they prioritize symptoms, control, and comfort? Are they leaning away from dialysis? And as they're sharing these kinds of thoughts and feelings with me, we kind of naturally move down that conservative care pathway. So I wish I could say there was an exact time, certainly earlier the better is always helpful, I guess, in terms of giving you more lead-in time to have these conversations. But there isn't a necessarily a best time or specific time.
Thank you. This is from a healthcare professional. This person says, I have a patient on peritoneal dialysis considering conservative care. What resources can I give her?
In terms of what's available on the web, I have to say it is I think different dialysis providers do have some information on their websites about conservative care. I would say that there isn't a lot, I think, from these kinds of sites. So I believe DaVita, DCI, many of the major dialysis providers do have this information, so that's something that they can access. Other places that I might access there is the Renal Network of Supportive Care. And I can send this a web link to Mike or to Ashley here heading up this webinar to make that available as a resource. And this is a website that describes conservative care, describes different resources that are out there for patients. Another place that might be helpful is the American Academy of Hospice and Palliative Medicine. So their website also has some information and links on where to go to from here. Sometimes you can even give your local hospice agency a call. So they're probably an agency that sees a lot of these patients and can tell you a little bit more about what their role has been in the conservative care process. So that might be the first places to look or to direct your patient who's thinking and considering this. If you have a palliative medicine provider available in your health system or in your community, also bringing them into the conversation can be helpful as well.
Thanks, Susan. And on the kidneyfund.org website, we also have some information under medical management in this area. But Susan, if you send us any of those links, what we can do is when we archive this webinar, we can add those links to that page so they're all in one place.
Okay, sure, we'll do.
A question regarding the table you showed with the different studies showing life expectancy for patients choosing dialysis or choosing conservative care. The person asked, what do you think the results would be if that same study was done in the United States? It's
tough to say. I actually have some preliminary work on it. I do see a split in terms of longer survival associated with dialysis versus conservative care. But one of the things that I'm finding as well is that there's very late transition to palliative medicine and hospice that tends to occur in the last 2 to 3 weeks of life, and I think that might be playing a pretty significant role in why life expectancy, if you're measuring the clock on survival at a GFR less than 15 or 15% kidney function, that we see that survival is more limited in patients who are receiving conservative care than dialysis. In that table that I showed, these other countries, they have much more established conservative care programs where patients are connected with palliative medicine and hospice services very early in the disease trajectory, and so are getting that extra layer of support early in this process of conservative care. We know that in other patients, so patients with cancer, heart failure, COPD, or chronic obstructive pulmonary disease, we know that from clinical trials that early palliative care is associated with better symptom control, better quality of life, sometimes even longer survival in these patients as compared to people who don't get these services. And so I have a suspicion that why in my preliminary data, looking at survival between patients who get conservative care and those who get dialysis, there is that split. maybe because they aren't getting connected with these services early enough in the course of the disease.
Thank you. So a question really for you specifically, what has been your greatest challenge in championing conservative care?
I think what's hard about championing it, I don't know if it's necessarily championing conservative care, but even offering conservative care may be difficult, I think, for some of my colleagues, not just in nephrology, but I think physicians and providers that I've worked with in general, is because I think we've gotten very much into the habit of always offering dialysis, that dialysis now has become the norm and the normalcy, and we forget that our patients are diverse and varied, and that not everybody is interested or wanting dialysis. And it's sometimes hard for us to remember that our patients can be so different. And that conservative care is an option. I think also with conservative care, talking about conservative care or dialysis, I think it's hard to talk about serious illness and what to expect and what lies ahead for them. I think words like hospice, words like palliative medicine in our community has made take some negative stigma. I think what's out there, people don't know much about it and don't know how to talk about it, or what they've heard may not always be positive. And I think those kinds of issues has made talking about conservative care difficult.
Thank you. Question from a patient that's listening. Can you start conservative care and then change your mind to go back on dialysis?
Absolutely. And some people do that, and vice versa. I've had patients who tried dialysis for several weeks and said, this is not what I thought it would be. This is not, and so patients can flux between one or the other. Absolutely.
Okay. Another question from one of our patients listening. Are you still getting treatment in a dialysis center with conservative care, or is it in another location?
It won't be in a dialysis center. It's often either in the clinic or at home. And most of it may start off in the clinic, but again, depending on a patient's energy level and their willingness to keep coming into clinic, because who wants to keep paying for parking and getting stuck in traffic and things. When they're ready to kind of shift the care to be focused at home, then we shift the care to being at home. Some patients live alone. Some patients may live in a situation at home where they may not feel safe, they may not feel comfortable having care come to them at home. And some of our patients may choose to move into an adult family home where there are others around, also some backup there. So depending on what their needs and what the logistics are for them. But often it's certainly not in a dialysis unit. It's either at home or an adult family home or in the clinic.
Okay, I think we have time for about 2 more questions. This one from a healthcare provider. What are the signs that a healthcare provider should look for when considering if conservative care could be an option for a patient?
I think when patients show maybe ambivalence, hesitance, maybe go so far as resistance to thinking about dialysis or kidney transplant, preparing for those treatment options, I think it's an opportunity to take a pause and check in with the patient about what their views are, and to bring up conservative care as an option as well. I think we certainly, and I am guilty of this too, in clinic, spending probably more time talking about dialysis and medical therapy, preparing for dialysis and things like that, than just taking a step back and seeing where the patient is in terms of acceptance of what a life on dialysis is. And I think by checking the temperature of the patient on their views about dialysis, I think it opens the door to then talking about whether conservative care might better fit their needs.
All right, one last question. Someone just is looking for if you could clarify the difference between conservative care and palliative care.
Actually, I would say they're quite similar. Some people use them interchangeably. Palliative medicine, I would say they can be used often interchangeably, because I think philosophically they're very much the same. How would I think palliative medicine, I think is more of a bigger umbrella term. Palliative medicine is practice with different disease types and across different specialties. And by conservative care, what I mean is a care that is focused towards patients with kidney disease. So sometimes their treatments, sometimes their experience is going to be different from, say, somebody who has developed cancer or heart failure and things like that. Palliative medicine, we use a lot of palliative medicine techniques and concepts in conservative care for end-stage kidney disease. I'd say palliative medicine is kind of a bigger global conceptual approach to care.
Perfect. Well, I want to thank you again, Dr. Wong, for an excellent webinar and for spending so much time answering questions. I know I learned a lot from this. It looks like our attendees did as well. So thank you very, very much.
And thank you so much for the opportunity to speak with you and your audience.
Great. All right. Have a great day.
Thank you. You too. Bye.
Our next webinar will be held on Tuesday, May the 30th from 2 to 3 p.m. Eastern Time. In partnership with Satellite Healthcare, we present Humanizing Dialysis with Satellite's Chief Medical Officer, Dr. Brigitte Schiller. Choosing the best type of treatment for kidney failure is a tough choice patients have to make. Dr. Schiller will share real patient stories to showcase how matching a treatment method to a patient's lifestyle can have monumental positive effects. Learn more about how we can all work to humanize dialysis. Mark your calendars to tune in. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When the webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. Thanks once again for tuning into our webinar series, and we'll see you again next month.